Hi there. My question's for Dr. Deeks. When you announced that it was AstraZeneca could be given to people who are 30 and older, you also said, and it's a quote, if the individual does not wish to get the mRNA vaccine, that's a reason that they should potentially be able to wait. Dr. Henry, Dr. New, every doctor in the country has been telling Canadians the entire time to get the first vaccine that is available to them. So why are you saying that people could potentially wait to get a Moderna or a Pfizer when an AstraZeneca could be available to them?
What we've said is that there should be individual choice. So we've made the recommendation that anybody who, because of the risk of the very rare risk of it, does not wish to receive that vaccine, they should be able to wait and receive a mRNA vaccine. Ultimately, though, NACI just makes recommendations. So the vaccine policies throughout the country are decided by the provinces and territories. But that is what we have said within our statement. Just saying, Dr. Quash, if you have anything to add to that.
I mean, I think you've captured it very well, Shelley. I think the bottom line is like everything, a risk-benefit analysis. So we do agree that what we want is to vaccinate Canadians as quickly as possible. However, if you are in an area where there is no COVID transmission, if you have no contact with the outside, or if you're able to shelter through public health measures, then there is a possibility to wait for the mRNA vaccine. I think that what was intended was to say, if somebody decides not to take the AstraZeneca for some reason, that person should not be put at the end of the list of the mRNA because of in terms of their priority. So priority remains priority, but if you do want to get a vaccine earlier, I think the AstraZeneca is a safe way to get to be protected. Thank you.
But I just don't understand why there's any conversation about potentially waiting. Like, just to go back, Dr. Henry and Dr. New, I'd like to hear your opinion on this as well. Every public health official in this country has been begging people to get vaccinated as soon as they can. So why is NACI even introducing into a conversation about potentially waiting to pick and choose a vaccine? This is precisely what Dr. Tam and Dr. New tell us every day that we should not be doing.
Yeah, no, I understand. I think that what is being said here is that depending on where you are in the priority list, if you're 60 and over, next week you could be able to get this mRNA vaccine. So it's just a matter, when we made this risk-benefit analysis, we took into account the time one would have to wait to get the mRNA vaccine. The UK used a 4-month wait. We were in terms of weeks, between 1 and 7 weeks, depending on where you were on the priority list. So that is just, we are being fully transparent, explaining exactly how we made our recommendation. And that is what that was the basis for our thinking through this question. Thank you.
I'll just add to that you're absolutely right. The basis of all of our programs in this country are particularly Pfizer, because that's the vaccine that we have the most of, and the Moderna vaccines, and we have the added benefit of having AstraZeneca and hopefully soon the J&J vaccine too. And we are targeting those in most of the country to different areas, particularly hotspot areas. And because most of our programs are based on age, there are some people that are not yet eligible for the main part of the program. And the AstraZeneca is an important vaccine for us to have available, especially right now, because it protects people really well from hospitalization, from ICU, and it protects your community too. So we are still, and my counterparts across the country, when we're in this phase that we are in right now, having whatever vaccine is available to you, and we would encourage you to take that. They are all safe and effective vaccines, and we've seen real world effectiveness of both of or all three of the vaccines that are available right now in Canada. We do recognize that some people will not want or will not be able to take the AstraZeneca vaccine, and they may choose to wait if they can protect themselves using public health measures. But absolutely, I encourage people to get the vaccine that is available to them first. And I can tell you members of my family have received AstraZeneca vaccine on my recommendation recently.
Thank you very much. We'll now move to the next question. Prochaine question, opérateur.
Thank you. The next question. La prochaine question est de Lauren Pelly from CBC News. Please go ahead. Your line is open.
Hi there. I know that you are obviously just recommending these changes to who can access the AstraZeneca vaccine, but I am wondering if you have any insight, these rare serious blood clots that are occurring, how are they treated now? Have we made any progress understanding them? Can you just share a little bit on, these rare cases, as more Canadians may be getting these shots, we may see more. Do you feel that we are prepared to handle these rare instances when they happen?
Carolyn, over to you for that one.
Yeah, so I'm not sure exactly who is best placed to answer this because we are really looking at the vaccine and not the treatment. The best people are, of course, your hematologist specialized in thrombosis. From my understanding, being a pediatric infectious disease specialist, not an adult one, so not seeing that many clots in general, in terms of treatment, when we use IVIG and non-heparin anticoagulants, the outcome seems to be better. However, as you said, we're going to see more and more. I think that as we pick up those cases earlier, the outcome will be better. And as healthcare workers become more acquainted with this with this entity, the treatment used is going to be also better targeted to that, because a regular clot would be treated with heparin, and if you have very, very low platelets and at risk of bleeding, you would transfuse platelets. But it's very possible that in this particular case, these treatment would just worsen the condition. So I think that that's why making sure that our healthcare workers are absolutely knowledgeable about this entity is key to have better outcomes post-treatment. But in terms of latest treatment discoveries for the VIT, I could not say more. Thank you.
I will just say, to echo what Carolyn said, this has been another part of what we need to do to make sure that we're prepared for this. So we're putting out messages to people about what to look for, what the time frame is, and what the signs and symptoms are, so that they can get assessed and treated early. And we have a good information that's coming out from the Public Health Agency around that as well. We have a network of clinicians across the country with a key clinician in each province and territory who is working together to be able to support family docs. So it's a hematologist, somebody who's used to dealing with the blood disorders, where this phenomenon has been seen from other things. We call it either autoimmune induced or heparin induced blood thrombocytopenia. So it's not an unknown entity. It is not a common entity that we see in public health or in infectious disease, but it is something the hematologists are quite familiar with. So having that network of clinicians to support the family doctors or the emerge doctors who are assessing people is really important too. But we must remember that this is rare. So that's why having some key people that anybody can talk to, any clinician can talk to if they're concerned about this condition in a patient is important.
Yes, and it's Dr. New. Maybe I just ran out the answer with my two colleagues. You're right. Certainly myself as well, I'm not a hematologist. If I do anything clinically, it's more in the world of adult tuberculosis. So similar to Dr. Quash, I wouldn't be able to tell you about the latest treatments. But as Dr. Henry also alluded to, certainly the role of the Public Health Agency of Canada, we're sort of a facilitator convener. So we've been making the connections, recognizing there's a well-established group. I call it a community of practice among the hematologists, the specialists, the clinicians, in terms of exchanging best practices, what they're learning from each other, learning from their international colleagues. So anything we can do to help support that in terms of making sure that the right information on the latest treatments is disseminated. And also, not that everyone has to know that, but at least in terms of the connections between, as Dr. Henry said, be it family physicians on the front line, being able to connect to a specialist or hematologist who would then have that information based on their exchanges with their community of practice. I think that's the way we're obviously making sure that Canadians can be assured that the treatments are available and accessible throughout the country. Thank you.
Thank you, Doctor. Any follow-up?
I also thank you for all of those answers, by the way. I just want to check as well how closely you are following the Johnson & Johnson concerns south of the border. since fairly soon we will have two vaccines being used in Canada that are both being linked to these rare blood clots. So just anything you can share on what you're looking ahead to now.
Dr. New, maybe I'll start first because I think that the process, it's sort of repeated itself a few times. So that's good, though. Certainly, I can't speak for Health Canada, but also being another, quote, a federal department, but independent as a regulator, I know that they're in close contact with their counterparts in the U.S. as well as international regulators, looking at the latest data, the safety signal, seeing what the data is in terms of the safety signal and so on. And once they have all that, they'll obviously do their own analysis and come forward with the results of their safety review. Then in turn, NACI, I know, is chomping at the bit, as they say, to obviously get that information, the results of the analysis, the safety review from Health Canada, as part of their deliberations in terms of any recommendations they would develop with respect to the use of that vaccine here in Canada. And then, of course, at the end of all that, looking at Dr. Henry, it's provinces and territories that take that all into account. They'll have seen what Health Canada has pronounced on the safety, and efficacy of the Janssen vaccine. Also, what the NACI will be coming forward with in terms of any recommendations, and then obviously having to take into account their local epidemiology, other contexts, other considerations, will obviously operationalize it to their best advantage.